So it is really my great pleasure to introduce Rick Allen, who is the CEO of MedSend. And the background to this talk on capacity building in mission hospitals is that over the past 20 years or so, there's been a movement to use church and mission hospitals, particularly in low resource places, to train local physicians in specialized areas like surgery, pediatrics, orthopedics, obstetrics, gynecology, as well as family practice and other areas. And these programs have been successfully graduating individuals who've excelled in their testing and professions. The programs, with rare exception, have been up till this stage small, and their growth has been constrained by limited resources across a broad range of needs, such as infrastructure, well-supported, well-prepared support staff, dependable supply chains, particularly in COVID times, and a financial sustainability model. And the challenge going forward, therefore, is to address the issues in order to scale up these programs so that there's an opportunity for more Christ-following physicians and dentists to serve and lead in Christ's name. I can think of few people better to talk about this than Rick Allen. Rick spent 25 years in executive roles within the computer software business. He was called out of business to be a pastor and run MedSend, which provides grants and scholarships for healthcare professionals to live out their calling. And Rick stepped away from the role as pastor several years ago to become the full-time CEO of MedSend. And his desire, as you'll see, is to see many to come to know the love of Jesus through the delivery of compassionate healthcare. Rick, it's a wonderful privilege to have you on the program today, and we look forward to hearing your talk. Thank you.
So the talk that I have prepared for you is what is going on? How are we building capacity in the current mission hospitals? And the focus really is on current mission hospitals versus the new ones that might be going up and in various parts of the world. So there is a number of initiatives that are going on. I'm happy to report that African Healthcare Mission has an initiative going on to support mission hospitals. And that has been very successful. And by the way, I'm going to be talking essentially from a U.S. perspective, right? I am based in the U.S. MedSend is based in the U.S. I'll talk a little bit about what we do later, but these initiatives are really within the community where MedSend tends to participate most. So African Healthcare Mission has an initiative underway. Christian Connections for International Health also has a wonderful initiative, 30 by 30, to support mission hospitals. The Medical Benevolence Foundation is doing great work in support of mission hospitals. And then the initiative that I'm primarily involved in, which is the Institute for Global Healthcare Missions, which is just getting underway. And I'm going to share a bit of a story around this institute so you have some context for what it is. MedSend, for the first 20 years of its existence, was designed to help U.S. healthcare professionals serve on the mission field once they had finished their education, if they had educational debt, which is a significant impediment here in the U.S. To serving in missions. And what we were finding back then was that individuals who felt like they might be called to serve globally were instead deciding to take 10 years, pay off their educational debt and go. And of course, life happened in between and they wound up never going. So MedSend was created by CMDA. We were a ministry within CMDA for the first 5 years of MedSend's existence. And we specifically take individuals who are interested in long-term service in healthcare missions and make their monthly payments for these educational loans that they have. So over that period of time, this year we will be celebrating our 30th anniversary. And over that period of time, we have helped to free up about 650 individuals from their educational debt, allowing them to go serve everywhere in the world, including here in the US. There's inner city Christ-centered clinics here in the US and many mission hospitals. So about 10 years ago, we started to ask if there was a way that the Lord might be calling us into other areas. And from that came the MedSend National Scholars. And what we're doing through the MedSend National Scholars is we are providing a scholarship for individuals who are training in mission-based residency programs. And as Peter mentioned, there's a large number of them, a large number of specialties. Right now, we have provided 60 scholarships for individuals to go through these 4 or 5 year residency programs. Well, once we realized that this was going to be a success, we started to ask questions such as, what would it take a few years from now, maybe 10 or longer, to actually have 650 or 1,000 individuals that we had provided these scholarships to. And that led me to speak to a couple of the hospitals and their leadership and ask them, what would it take for us to scale your program, to make it larger? You've got 3 people in your program today. How could we make it 15? You've got 10 people in your program today. How could we make it 30? And in general, the infrastructure and this both physical plant as well as the support structure could not handle that kind of scalability. And most of these leaders, although excited by the prospect of being able to expand their programs, really were not in a position to make it a reality. So I came back and counseled with a number of people, and we came up with a model that said, what if there was an organization that would be willing and able to come alongside of you for an extended period of time, let's say 10 years, with significant financial resources and significant subject matter experts to help you in all of these areas that would need to be addressed in order to scale your residency program. And of course, everyone felt that that would be the kind of resource that would make it a reality. So from there, the idea of this Institute for Global Healthcare Missions was birthed. That's how we started it. That idea germinated about 2 years ago, and it has been in process since that time. I'm not going to go into all the details of what has happened, but the organization itself is preparing to launch. It will probably start its initial efforts, which I'll explain in a little bit more detail later, in late spring of this year. So again, let me just share my slide with another slide with you so you can get a context of what it is that this organization will be doing. We're really looking to partner up to 10 years with these hospitals to help them improve the pie slices in the middle. So we're focused on infrastructure, education, human resources, supply chain, and governance. And I'm going to go into a little bit more detail, but the model is going to be using partners in order to be able to do those various efforts. The organization itself, if you start at the top left-hand side, there'll be a think tank as a component of this, really trying to mobilize and understand the needs globally, where there might be opportunity to invest and to come alongside of the leaders of the hospitals that are ultimately selected. Going across to the right-hand side, there'll be project managers, which will help to manage the partners who will be doing the activities in the pie in the middle. Healthcare member care, one of the things that we hope to continue to support is sending healthcare professionals from the West, primarily from the US is where our focus is, to these mission hospitals for a period of time. So we want to keep the flow of people from the US into the mission hospitals as trainers and as support staff. And ultimately, we will be, in an ideal world, the individuals that we have trained will then become the trainers over time. And we're already starting to see that now that we've got some critical mass of 60 plus individuals who are in the program. We want to create a repository that would be available to all of the community that would be collecting data and then making some analysis on it. And then generally publishing this information and making sure that we're all on the same page, if you will, that is within the context of the community, those involved in global healthcare missions. Here in the US, we would do quite a bit of awareness building and then ultimately fundraising, because we will, as a part of this, our anticipation is that we will be providing the resources necessary in order to accomplish the elements of the pie in the middle. So I'll just take apart each piece of the pie. I think for most of this audience, you'll understand. And also, I just want to state that this is a limited view. This is not meant to be comprehensive. It is what we're the high level efforts that we're anticipating we're going to be stepping into. There'll be much more detail behind all this. But it is a place to start and to build some context. One of the reasons that we're doing this is there's some we've observed in a couple of places, and hospital leaders, mission hospital leaders have confirmed that oftentimes a lot of the focus is on infrastructure and education, meaning they go and they bring in one of our wonderful partners to provide curriculum and guidance on the education, and they might build out some of the infrastructure. But if you're really looking to scale, you need to have all of your support staff, nurses, lab techs, pharmacists, accounts payable and accounts receivable clerks. Everyone needs to increase in their skill set in order to really be able to scale for one of these programs. You need a reliable supply chain so things don't get held up in areas like customs. Sometimes, depending upon the country or region, this can be very challenging. And then ultimately governance, good oversight of the programs. So when we look at infrastructure, these are the kinds of things that we're looking at. Of course, again, not comprehensive, but at a higher level. Just roads, can you get to the place? Is there a reliable model for people to access the hospitals at an increasing scale? Buildings which are apparent, but they go anything from waiting rooms to dormitories to surgical centers. Water and sewage, if you're going to increase capacity significantly in the number of people who will be using the facilities, you obviously need to upgrade that. Communications, we're all very dependent upon global communications today, as well as security. So these are the kinds of things that we will be working with the leadership of the hospitals in order to improve over a period of years so that the infrastructure can support the expansion. And then education, curriculum, faculty, certification programs where appropriate, sometimes within countries, regions, employment readiness, really trying to prepare the individuals who are going through these educational programs to be ready to be employed within the region. So making sure that the programs themselves are preparing for regional employment. And then government and regional bodies. We have a sense that we need to better communicate and fit in many cases, not all, and your situation or circumstance may be different, but we want to make sure that we are participating in a broad-based approach to healthcare. And that includes all of the governments and also secular organizations such as the Gates Foundation, which we're starting to see more and more influence exerted by these additional parties. And we want to make sure that we are at least listening to what they are doing and what they perceive the needs to be, so that we can fit into the broader community of global healthcare. We're seeing quite a bit of transition occurring, which is good. Healthcare is becoming much more readily accessible. Still not in some of the areas where we have hospitals, but there is significant global improvement. Human resources, this is preparing your people to support this level of build out. So we're looking at education and college partners, things like a college to help train and improve the skill sets of nurses, for instance, of hospital administrators, looking at trying to potentially get certification programs for your front office people. Going further along, we see tech support, making sure that we've got the right people to provide the support of technology, which is becoming so critical today for us. Policies around retention, trying to understand what the people's needs are, and trying to retain the individuals that we will be investing quite a bit of money in, and then moving on to the next area, which is supply chain. And this is an area that can be very challenging, but we're looking at vendor management, understanding and getting reliable vendors to supply all the needs, ideally as locally as they can be sourced, port management for things that need to be imported, lead time management so that we can better understand when to place orders and when somewhat predictably things will be running out so that we can place the orders in advance. And then finally, the financial requirements that are necessary in order to secure the equipment. And then finally, governance, which is a focus on the board itself. Does the hospital have a strong board in place? And training up and providing appropriate skill sets for the senior management team, helping them to grow in their professional lives, policies for oversight, and then sustainability models. And I recognize that many of our mission hospitals are in areas where financial sustainability will be very difficult to accomplish, but we need to look at the models that we have in place and at least recognize that sustainability is a goal or an objective, and be moving in that kind of direction. So that's the perspective that we're bringing to this initiative. I firmly believe that we should be able to launch with the first 3 sites. They have already been identified, and just to set expectations, the anticipation is that we will work on these first 3 sites for 2 years. So I'm not anticipating identifying another site until 2025. essentially what we will do is to come into these 3 sites, partner with them, identify how to improve each one of these areas, what they believe their needs are, and then create a Gantt chart or a plan over a period of time that would allow us to assist with the financial needs as well as the human resource needs, the individuals who will be helping with this, partners, if you will. So this is the major initiative within the Institute for Global Healthcare Missions. We are seeing just a tremendous expansion in the number of hospitals who see themselves as having a desire to train, to come alongside of individuals, and we want to support their movement. This is going to be kind of a ground up, if you will, in the sense that our effort is to support the leadership of each one of these organizations so that they are able to accomplish the goals and objectives that they have set for themselves with regards to becoming a significant teaching institution. So the anticipation is that this will start initially with physicians, but we're also looking to partner. We realize the importance of nursing, and we're looking to partner with organizations and institutions that are committed to training up nurses as well. So we see both of these as opportunities going forward to train up both physicians and nurses. This initiative is based out of both Africa and Asia. So our first 3 institutions that we've identified, one is in Asia, 2 of them are in Africa. We will plan to work with hospitals that are visioning a program. They haven't started an educational effort yet, as well as ones that are willing and ready to expand the program that they have in place. We think we can provide support for up to 20 organizations over a period of 10 years. And this initiative is anticipated to last up to at least 2 decades. So we're trying to do it at a pace that is sustainable, that is realistic, and that ultimately will significantly increase the number of Christ-following healthcare professionals in these regions. And ultimately, if we're successful, we really believe that these individuals will be leading their national healthcare systems, regional hospital systems, and delivering quality, compassionate care in the countries and regions where they serve. So that's the ultimate objective of what we're trying to do here. I will tell you that most of the partners are already in place. You might be aware of organizations such as PACS or CURE. Another partner is in his image. We're also working with InfoMed, and these are all organizations which are looking to provide curriculum and support for educational programs, residencies for national physicians. So we're anticipating that this, when we're done, we should be able to come alongside of literally hundreds of individuals and help them with their training. Now, this organization will be entirely separate from MedSend. We have partnered to help to make this a reality, but it will not be MedSend itself. MedSend will be a member of the Institute. So we do anticipate that it will be a standalone organization that we will support, and anticipate that it will support us as well. So we're in a launch phase at this point, and we do believe that the level of initiative that is occurring today, that we should be able to provide through all the efforts, not just this institute, but our other partners, that we should be able to significantly increase the capacity of mission hospitals going into the future. Some of them have, the infrastructure needs improvement in order to be able to move into this type of training environment, and that's where we'll focus our attention. So Peter, I'm available to take questions. I've kind of given the general broad context of what I wanted to talk about, and I can try and address specific questions.
Thanks very much, Rick. That's a fantastic overview of what you're doing and what an amazing vision going forward. And you're planning it very sensibly over a long term as well. Well, there are quite a few questions have already come in. Just to start off, Rick, you talked about MedSend's own history, how it began paying off the debt of American missionaries serving abroad to enable them to serve. And then you talked about the move to sponsoring trainees as well. You said you had about 60 trainees that you trained already around, or at least provided for the training of. Could you just give us a bit of an overview of those 60? What sort of skills are they training in? What countries, what hospitals, just to give us an idea of the spread.
So the way that we're working is we work through our partners. So I'll just give some context for the way the process works. So an individual would apply, and I'll just use PACS as it's connected as we were to CMDA and has a history within the context of CMDA. So PACS is one of our partners. So an individual would apply to the PACS program. Once they were accepted, PACS would then submit an application to us for them, and the MedSend board would review the application and then, let's say, approve the application. So really the organizations, our partners, if you will, such as PACS, really are the ones that make the assignments, right? They're the ones that understand what the hospital location that they will be training at, what their area of specialization will be at. You mentioned several of them at the beginning. So to a certain extent, to a large extent, MedSend is not making those allocations. We're really not even making the selections, if you will. You can't directly apply to MedSend. If you're an individual, we don't take applications. They only come through our partners. And our partners generally are working in Africa and Asia. So the hospitals themselves tend to be in Africa and Asia, and the specializations are then defined by the partner. So we have two primary areas, surgery, which is through PACS and CURE, and then family practice, which is really primarily through InfoMed. And we're looking for partners who are actively running programs, have curriculum, have process in place. But as you know, if you're familiar with these organizations, they have been providing these educational programs now, in some cases, for a couple of decades. So they know how to administer the programs. They know how to come alongside of the hospitals. And we're excited to be able to support the individuals who have been accepted into these programs.
Thank you. That's really helpful. And webinar attendees may actually have heard both Keir Thalander from PACS, the Pan-African Academy of Christian Surgeons, and also Chris Larby more recently, who worked with Cure, talking about orthopedics in Africa. So these are the kind of programs that we're talking about. With regard to the hospitals, Rick, you said you've got 3 sites ready to go, and you'll be focusing on them in the first 3 years, and then broadening it out to include more, another 20 organizations, or 20 in total over the 10 years. When you're looking at institutions to decide which ones should we partner with, what do you look for in an institution that you're wanting to improve the capacity of for training?
Thank you for that question. The most important thing, quite frankly, is leadership. Is the leadership of the institution ready to be able to work through the level of change that would be required in order to scale one of these programs? It's very challenging. And the greatest challenge, frankly, is the human resource component, right? It is looking to providing leadership to the team at the hospital and getting them on board for this level of expansion. Generally, it means that there'll be extra work involved, quite frankly. And but there are other restraints, reasons why people might not want to participate. And we're looking for strong leaders with strong vision that we can come alongside of. So, Peter, I would say that that's the first thing. The second thing really is the region or location of the hospital. If you're going to scale a training program, do you have enough demand? Are you in a region where you'll be able to keep all of the residents productive? Frankly, some hospitals that we really believe in their ministry and their mission, they're just located in areas where they can't scale. We'll continue to work with them. If their program is small, MedSend will continue to try and help to get scholarships for their residents. But IGHM is really going to, this institute is really going to be focused on institutions that have enough demand that they could scale up a program like this.
Thank you. We've got a question here from Angel Wang in Burkina Faso, West Africa. She's saying, as you said, over the last 20 years, there's been a movement to use mission and church hospitals. What's different about this century, 21st century? What's different about this that's making this need for training and building the capacity of national institutions a real priority for you? Perhaps just your reflections on the wider trends in healthcare that are making this a priority now that you feel you should go for.
That's a big question. I'll start at the top and work down. I believe it's a movement of the Holy Spirit, right? I believe that God is involved in this. I believe that healthcare is the model that Jesus created, right? So preach and heal was his model. So I believe that we are seeing healthcare as a revived model. And I also believe that one of the reasons is access, that a healthcare professional is welcomed in almost every country in the world. A well-trained, well-prepared healthcare professional. Most nations, most communities, and even most tribal chiefs will welcome a well-prepared healthcare professional into their area. So this provides us access. And then healthcare in itself, delivered in a compassionate way, provides a model of Jesus. So we have this incredible ability to reach places that are not accessible to other forms of a witness, if you will, that healthcare provides. So I really do see those impacting it. And finally, we, as the world continues to expand, as educational facilities become available, as the economies of many nations expand, we're seeing individuals being able to afford advanced education. So we're now seeing more physicians, more nurses, more support infrastructure, individuals being prepared well, and that allows us to expand these programs. So this is all happening at the same time. Now, some, I'm speaking very broadly here, and I recognize that. But some of the infrastructure has been around for 100+ years, and in some cases it's been neglected. The resources have not been available to maintain it. And I think that this is, such a time as this, right now, to be able to help improve that infrastructure. I just believe that it is God motivating wealthy donors to be able to come alongside of us and shore this up. I do believe that the role of the West is changing significantly. And I believe that our responsibility is to support current leaders in carrying out their vision, their God-given vision for these hospitals. And we want to play a part of that.
Thank you. That's really insightful. I was struck by your comment at the beginning. You identify these 5 areas of need in your pie chart, and you said something that struck me is that it's not just about education and infrastructure. You need human resources, you need supply chains, you need governance, and also your comment about leaders with vision. And we've got 2 questions here from Howard Lyons, who's on the ICMDA board, and Laurie Allett, who are both asking the question about hospital administration and healthcare management. What do you see? Is MedSend involved in this, in training healthcare managers, hospital administrators? What do you see for the place of that in the future?
Yeah, I'm very excited about what's happening in that area specifically. I know that we're starting to see a number of initiatives that are focused on training up individuals specifically to go to and to provide support to mission hospitals. There is an initiative that's underway here in the U.S. at the US-based CMDA to bring together hospital administrators. MedSend as an organization recognized this need several years ago, and our board has approved the debt repayment, the educational debt repayment of individuals who have a degree in hospital administration. However, these are US-based institutions where they're getting their education, and much of what they learn isn't applicable throughout the rest of the world. So we're really looking for programs that are locally based at universities, particularly if it's at a master's level, but we certainly would consider individuals at a undergrad level. To provide better administration into the hospital. So there is a number of movements going underway. There is a movement in Kenya where they're looking to put together a training program, and initially as a certificate program, but ultimately providing a degree, a full degree. So we're starting to see a broader recognition of the importance of hospital administration. Certainly the Institute will get behind that. We're aggressively looking for institutions, colleges, in particular universities, who are providing this training within the context of the regions where these hospitals will be based.
Thank you. And the program in Kenya you mentioned is based at Tenwick Hospital, isn't it? Yeah. That's getting underway. And it may interest listeners also to hear that ICMDA is in the very early stages of planning a distance learning diploma in healthcare management, which we hope to launch in a couple of years' time, along the same lines as our diploma in family medicine that you'll be able to do from anywhere, provided you've got a good internet connection. A very popular question here from Jim Ritchie, Rick, who's asking, what would you do to prevent mission drift? The mission hospitals becoming more of, is the mission hospital in danger of becoming more of a well-financed resource emphasizing medical care rather than integrating the power of the gospel into healing? You've already talked about the Holy Spirit's mandate both to preach and to heal. What do you look for in programs in terms of spiritual formation and mission focus?
I really appreciate that question, because I think if there is a hole or a deficit in the conversation that I've had with you thus far, it is the focus on the spiritual component, keeping the main thing. And the question that we have before us is, are our efforts about bringing and improving the healthcare infrastructure so that others will be served? Or is it about bringing the knowledge, awareness of Jesus Christ through the delivery of compassionate healthcare? And where is the priority in the middle of that? And we believe that to differentiate ourselves, we really need to ask that question, and the answer is the foundation upon which we will stand. And I believe that Christ needs to be in the center of it. It is what we uniquely bring to the world. Healthcare can be delivered by governments. It can be delivered by for-profit institutions, and it is, and those areas are expanding. But there is a unique model that brings compassionate care in the name of Jesus Christ that still has value in the world today. And we need to be thinking these things through, because we will either be about delivering healthcare, or we will be about bringing healthcare in Christ's name. I believe in the focus of the Institute, as well as MedSend, will be prioritized around organizations that are committed to bringing the gospel, the message of hope, through compassionate healthcare.
Thank you. We've got an anonymous question here from someone who's worked in a missionary hospital in Africa, just asking the question, is our mission hospitals now an anachronism, just picking up what governments have broken or never achieved as a result of corruption or lack of commitment? Is there a future for the mission and church hospital in the developing world? There's a provocative question.
I love this question, and frankly, wrestle with it. I think the answer that I just provided is some insight into it, which is, in a world that is increasingly expanding healthcare through governments, through private organizations, through for-profit, what do we uniquely bring to the world? What does Christian-based delivered healthcare bring to the world that is unique? And I'll tell you, I don't necessarily have the answer, but I know a part of it has to be Jesus Christ. I mean, that is where our uniqueness is. Now, what is the context in that? Healthcare is very expensive to deliver at any level. It's expensive in today's world. We are seeing significant transformational changes in the players and the participants. We will be entirely marginalized if we can't answer that question. Why are we unique? There has to be an element of delivering and serving the least of these. If we are really delivering healthcare in the name of Christ, we need to follow the model that he set for us. And that is I believe, our unique contribution to the world.
Thank you. A question from Timothy Rice, who is saying, in addition to the 20 mission hospitals you'll be aiming to help in the next 10 years, are there plans to make best practices or other resources available to other mission hospitals who won't be touched? I guess we could say, well, we think there are probably close to about 2,000 church and mission hospitals in Africa and Asia at the moment, many of which don't have any connection to a Western or American mission society. But do you have any plans for that down the line in terms of, apart from just setting an example in what you're doing in terms of making resources or training available to others who might benefit other hospitals outside the 20?
Great question. So we will not stand in isolation. We will work alongside of others who are interested in creating opportunities for best practices to be shared across the board. And I mentioned some of our partners initially. CCIH has a very large network of organizations, church-based hospitals, and otherwise. We plan to work very transparently alongside of them, ideally as a partner to the efforts that they're doing. It is a very large challenge. They're looking at their initiative is 30 by 30. We're thinking about a context of about 20. And as you said, there's 2,000 institutions that we've looked at. So part of what we're hoping will come out of the Institute is the ability to mobilize and focus resources, but also focus the kinds of things that are working and the kinds of things that are not. So we just couldn't right now envision having the scope or the breadth to make an impact beyond the 20, but working and coming alongside of partners and making sure that we are focusing our resources on the things that we are bringing uniquely to this process. I think that'll help, and then sharing openly whatever we're learning and access to individuals and organizations that can help in this process. This institute will be primarily focused or exclusively focused on institutions that are looking to train, that are looking to be training institutions. But our partners are not necessarily constrained by that. They're looking at all kinds of various areas within the global mission healthcare infrastructure to support it.
Tim Love, who is, he says, a grateful MedSend grant recipient. He's working as a surgeon in Ethiopia and actually helping to lead the PACS program there. He says, sees lots of clinicians going out, being supported. Are there also healthcare administrators who are getting grants to serve abroad? Are you seeing an increase of those, and is MedSend supporting those kinds?
Well, I mentioned earlier that we are willing to support them, but we haven't had one application.
Wow.
To be honest, we haven't had one application. I don't think that there has been enough effort in making individuals in these programs aware of the opportunity to serve, and the opportunity that MedSend offers to help remove the burden of educational debt. I do believe that this check initiative that is being started by CMDA here in the US will increase awareness. So there's kind of two ways that we're approaching this. One is to identify individuals that we can support from the US to the world. And then the other is to identify programs that are in the continents where we seek to serve, specifically Africa and Asia, and help to provide scholarships to their students that are willing to serve in mission hospitals. So we're going to come about it in two ways and see if we can't, frankly, we're playing catch up, and there just isn't enough awareness. These are all reasonably new initiatives. So the answer to the question is yes, if we can find them, if we can find the individuals here in the US willing to go, and we can find the institutions in either Africa or Asia who are doing good job preparing hospital administrators, we'll come alongside of some of their students who are Christ-centered and willing to serve in mission hospitals.
Well, there's a great challenge. Just a question from Amy Henricks here about methodology, Rick. How exactly are you going to help these hospitals with the things you talked about, infrastructure, education, HR, governance, and so on? Are you doing this, providing this support largely as consultants, or are you sending people to do these things? Just say a bit more about unpacking the methodology.
Okay. So here's what we're anticipating, that this will all be done through partnerships, that it will be done through organizations and, where appropriate, individuals to deliver these services. Some of the partners have long histories building churches, building hospitals, building the infrastructure that's required for them throughout Asia and Africa. And we will specifically lean towards those organizations who use local resources. We want to make sure that we're trying to build the infrastructure. As we look at logistics and supply chains, we're going to try and identify local organizations that we can help build up. So that'll be a high priority, is looking for local resources in this process. The Institute itself will not do that. Just like, MedSend does not educate anyone. We don't send anyone. We play a very specific role in MedSend to the world, which is that we take care of this educational debt. We support others in doing the ministry to which they've been called, right? And we're going to do the same thing through the Institute. The model is going to be very similar, to the extent that we will take organizations who already are doing these kinds of things, and we'll provide the financial support for it to happen. So we expect, just as MedSend is, to be a large fundraising arm, mobilizing resources from the West to be able to be deployed to build out these mission hospital-based training programs. And that'll be the model. And we've already identified a number of partners who have the capacity, who have the experience to be able to do it. So I think we'll start to see results from this rather quickly. But the Institute itself will be a rather flat organization, deploying organizations. And then, as I said, we will also provide human resources, meaning individuals who are experts in particular areas. So it'll be a combination of those two things specifically. And then if you go back to my chart, those arrows that were on each side, one of the things that we'll be trying to do is to provide awareness to a broader context, both within the community, meaning those that are working in healthcare missions, as well as outside, looking at the opportunities that are available for those people who have a passion for supporting healthcare. And if that doesn't answer the question, you can refine it. I'm fine.
That's great. I just want to sneak another couple in at the end. And Doug Lindberg, who is also connected with CMDA, is asking the question about funding. Are you just looking to Christian individuals, trusts, foundations, institutions, or do you think there could be a place for getting secular funding from organizations like USAID, for example?
Yes, that's a very good question. And this comes back to the earlier comments about what are we uniquely bringing to the world, right? What is it that we bring to the world? And as long as an institution or organization funding opportunity allows the sharing of the Christian faith in the context of their support, absolutely we would. But we will, so to speak, wear that on our sleeve, meaning we will make that clear that the unique thing that we are bringing to the world is our faith-based, compassion-based delivery of healthcare that is driven by the model of Jesus Christ. So as long as they're willing to accept that, it's not proselytization to the extent that we will only serve Christ followers, as I'm sure all of our listeners recognize, but we will not walk away from that foundation in order to get secular money.
Thank you. And just a final question now from Bruce Dahlman. Bruce is involved in the leadership of CAP, which is, I'm sure you know, is a partner organization to PAX. So that's the Christian African Academy of Physicians. I think I probably got it slightly wrong there, but his question is, in terms of partnerships, and you've talked a lot about partnership, have you been in discussion with, for example, the ACHAP, the African Christian Health Associations platform, which is the umbrella body for all of the national Christian health associations in developing countries? Is there a partnership developing there with Christian healthcare and hospital associations, indigenous movements, which of course are umbrella bodies to most of the mission and church hospitals?
Yes, that's a good question, and my response is this: I like to dream big and start small. So all of these initiatives are in their incubation process. I mean, they are just getting started. Even the MedSend National Scholars Program is only in its 6th year. So we've put boundaries around our reach because I don't want to set expectations that we can't meet. So the answer to the question is not yet. No, we haven't approached them because we're not in a position to offer any significant partnership opportunity because it's just still too small. So I do see us getting to the point where this continues to, our reach continues to improve, but we have partners like CCIH who is, very well embedded in it and can keep us informed of what those needs are, of what the partnership opportunities are. So, we're scaling this at a rate that we think we can provide value to the community. And I don't want to set any false expectations. I mean, these are small initiatives.
Thank you. And that's a great note to finish on. Well, you mentioned CCIH, and of course, they are very well networked with all the national Christian healthcare associations and with ACHAP as well. But thinking big and starting small. One of my great heroes is Stanley Brown, Mr. Leprosy, who used to say, you cannot meet the need, but you can show how the need can be met. And in sharing about this best practice model, Rick, today, you've really opened our eyes to the way the need can be met. And I hope that those listening have been inspired and challenged and be assured of our prayers and goodwill as you take this project forward. And as you say, what starts small will become bigger and bigger and bigger by God's grace. Jesus started with 12 people, and look back over the last 2,000 years. So thank you so much for joining us today on ICMDA webinars. Rick Allen of MedSend, speaking on improving capacity in mission hospitals. So from all of us here at ICMDA, thank you very much. God bless you, and we'll see you again